Welcome to Group 12 Grand Rounds presentation. My name is Christine Basali. Today we're going to be discussing patient DM, who's a 63-year-old white male presenting to the pharmacotherapy clinic for a diabetes follow-up. At his last visit, he complained of GI upset from metformin and was changed to metformin XR formulation. He reports that he has not had any GI upset with metformin XR, and he's reluctant to using injectable anti-glycemic agents and would like to be treated with oral medications. He recently heard about Invokana on TV commercials and was wondering if he could use that instead. He reports that he had forgot to bring his blood glucose log, but he remembers that his fasting blood glucose was averaging between 160 to 170 milligram per deciliter, and his postprandial blood glucose levels were ranging between 240 to 250 milligram per deciliter. He also reports that he's still experiencing some heartburn, however his IBS has not been an issue. Patient DM has a past medical history of type 2 diabetes, class 2 obesity, hypertension, GERD, thyroid disease, low testosterone levels, lower back pain, diverticulitis, burns, and cataract. The patient also reports that he drinks on average 2 beers per week and has never smoked. His father has colon cancer and his brother had throat cancer. The patient also reports that he has lisinopril allergies. His current medications include metformin XR 1000 mg PO BID, Januvia 100 mg PO daily, amlodipine 10 mg PO at bedtime, losartan 50 mg PO daily, metoprolol 25 mg PO BID, atorvastatin 20 mg at bedtime, baby aspirin once daily, dicyclomine 10 mg PO BID, Nexium 20 mg every morning, testosterone injections 100 mg IM every 14 days, and APAP 500 mg PO every 4 hours as needed for pain. Patient's current weight is 124.7 kilogram with a BMI of 36.3. He's 6'1". His blood pressure reading is at 152/90, heart rate of 114. His current labs include a sodium level of 139, potassium level of 4.5, BUN of 14, serum creatinine of 1.16, total glycerides of 103, total cholesterol 165, HDL 48, and an LDL level of 96. His last reported A1C level is 7.3.
The problems of our patient include type 2 diabetes, hypertension, primary prevention of atherosclerotic cardiovascular disease, irritable bowel syndrome, and gastroesophageal reflux disease. Moving on with our first problem of type 2 diabetes. The patient's current medications include metformin, extended release 1000 mg twice daily, and Januvia 1000 mg daily. Our assessment is that the patient is not at goal A1C. However, the patient is tolerating the current doses of metformin and Januvia. The patient's goal is to get to an A1C level of below 7%, have a fasting blood glucose between 80 and 130, have a postprandial blood glucose of less than 180 per the 2016 ADA guidelines. Our plan is to continue the metformin and Januvia while initiating Invokana 100 mg by mouth every day prior to the first meal of the day. Also, it's quite necessary to counsel the patient on medication compliance and lifestyle modifications, as well as emphasize that if his condition does worsen, then injectable medications will be required for treatment. Our justification is that the patient does not want to use injectable medications, and also triple therapy is indicated after 3 months of duplicate therapy while still not at goal. Monitoring parameters include self-checking of blood glucose during fasting, after dinner, and bedtime every day, A1C levels every 3 months, as well as side effects of his medication regimen, notably his potassium, serum creatinine, and BUN levels. Follow up with the primary care provider in 1 month. Next off with hypertension. The patient is currently on amlodipine 10 mg at bedtime, losartan 50 mg daily, and metoprolol tartrate 25 mg twice daily. We assess that the patient is not at goal blood pressure where the goal is less than 140/90 per JNC8 guidelines. Our plan is to continue amlodipine and metoprolol while increasing the losartan dose to 100 milligrams by mouth daily. Our justification is that the patient's ACR was 51 back in January, which is indicative of kidney damage. ARBs such as losartan can help with preventing that. Monitoring parameters include daily self-monitoring of blood pressure as well as blood pressure checks at every office visit. Potassium levels should also be monitored every 3 months, and again, with just like with the diabetes, follow up with a primary care provider in 1 month.
Now for a pause point review question. True or false? The goal blood pressure for diabetic patients is less than 140/90 in both the ADA 2016 and JNC8 guidelines. The answer is true. Both the ADA and JNC8 guidelines recommend a blood pressure of less than 140/90 for diabetic patients. Now back to the assessment and plan. For primary prevention of ASCVD, the patient is taking atorvastatin 20 milligrams by mouth every night and aspirin 81 milligrams by mouth daily. The ASCVD risk for this patient is calculated to be 24.9%. The goal is to reduce risk of future ASCVD. Our plan is to continue aspirin and increase the atorvastatin to 40 milligrams by mouth every night, which is a high-intensity dose. We would also like to order a new lipid panel since the last panel was in January. ADA 2016 recommends daily aspirin for diabetic patients older than 50 years old. ACC-AHA recommends a high-intensity statin for diabetic patients who are 40 to 75 years old with an ASCVD risk of equal to or greater than 7.5%. For monitoring, we would like a lipid panel every 12 weeks and for the patient to monitor for signs of myopathy every day. We would also like to follow up with the patient in 1 month. Now for our next pause point review question. What information is required to calculate ASCVD risk score? Select all that apply. The answer is gender, age, race, HDL cholesterol, total cholesterol, if they smoke or not, systolic blood pressure, and also if they're receiving treatment for hypertension or if they're diagnosed with diabetes. Now back to the assessment and plan. For irritable bowel syndrome, the patient is taking dicyclomine 10 milligrams by mouth twice a day. The patient is well controlled on this therapy because he is not experiencing any symptoms of IBS. Our goal is to prevent worsening of IBS and to keep his symptoms under control. We plan to continue dicyclomine 10 milligrams by mouth twice a day because he's controlled on this therapy. We would like to monitor for IBS symptoms, side effects, and anticholinergic effects. We would also like to follow up with the patient in 1 month. For GERD, the patient is taking Nexium 20 milligrams by mouth every morning. His condition is exacerbated by his obesity, alcohol consumption, and an unhealthy diet. He is not controlled on this therapy because he is still experiencing symptoms, such as heartburn. The goal of treatment is to reduce GERD symptoms and improve his quality of life. Our plan is to increase Nexium to 40 milligrams by mouth every morning and encourage the patient to decrease alcohol consumption and avoid acidic foods in the evening. We would like to increase the dose because his GERD is uncontrolled with the current regimen and he has multiple factors and medications that exacerbate the condition. For monitoring, the patient should be counseled to self-monitor for frequency of heartburn and regurgitation. We would like to follow up in 1 month for this condition.
Alright, so this brings us to our pause point review question. At what BMI cutoff do the ADA 2016 guidelines recommend where bariatric surgery may be considered in a patient? Greater than 25, 30, 35, or 40 kilograms per meter squared? Alright, and the answer is greater than 35 kilograms per meter squared. So now we're going to dig into the oral medications and type 2 diabetes. So a little background on what actually type 2 diabetes is. It makes up 9.3% of the population based off 2012 data, and it's the 7th leading cause of death in the United States. So as you guys can see, it's very prevalent and it also occurs $245 billion in total cost of diagnosed diabetes. So not only is it very prevalent, it also costs a lot of money to treat as well as diagnose. So a little pathophysiology behind type 2 diabetes. If a patient has type 2 diabetes, their body doesn't use insulin properly. So at first, your pancreas makes extra insulin to make up for it. So the patient may have a poor diet or not as physically active. So your pancreas tries to make up for it, makes a lot of insulin, but over time it isn't able to keep up and can't make enough insulin to keep your blood glucose at normal levels. So when this happens, your body actually goes into insulin resistance, and then you have impaired regulation of the hepatic glucose function. The beta cells are what actually secrete insulin, so over time you have decreased beta cell function, warranting additional therapy and pharmacotherapy to treat elevated glucose levels since your body is not able to. Again, usually it's because of poor diet and lack of exercise. In diagnosing based on the ADA 2016 guidelines, it talks about if the patient has a fasting plasma glucose greater than 126 milligrams per deciliter, a random glucose greater than 200 with signs of hyperglycemia, and those are the polyuria, polydipsia, maybe unexplained weight loss. Those types of things kind of hint us to diagnose type 2 diabetes. There's also another test that we can also do, the oral glucose tolerance test. And this involves the patient ingesting 75 grams of glucose and checking the plasma glucose 2 hours post the injection. And if the labs come back greater than 200 milligrams per deciliter, deciliter, yes, then the patient most likely has type 2 diabetes. Another test that we can also run is a hemoglobin A1C. And if the A1C is greater than 6.5%, then the patient is most likely to have type 2 diabetes. So monitoring. Based off ADA 2016 guidelines, if a patient does have type 2 diabetes, we want to make sure they're on appropriate therapy to get them to specific glucose targets. And the whole idea of getting a patient to the specific glucose targets is due to the risk of microvascular and macrovascular complications. So retinopathy, neuropathy, nephropathy are the micro, and then the macro is the heart and the brain. So in order to make sure that the high blood glucose levels don't progress to damaging of micro and macrovascular complications, we want to aim for these glucose targets. So an A1C less than 7% is acceptable unless the patient may be elderly or has a history of hypoglycemia. Then we may want to target a less strict goal of less than 8%. Also, a fasting blood glucose between 80 and 130 and a postprandial blood glucose of less than 180 is appropriate. An A1C test should be then the standard monitoring parameter that the patient has with the PCP, as well as home blood glucose monitoring. But the A1C test can be done at least 2 times a year in patients who are stable. And then if they're unstable or if we just got done adjusting their medications, then we can test the A1C quarterly. And the A1C gives us a great picture of a 3-month span of how well or how controlled the patient's blood glucose is. If the A1C is around 7%, we can kind of assume that the average blood glucose over those 3 months is about 150 milligrams per deciliter. Then we want to encourage the patient to get yearly foot and eye exams, again because of the diabetic peripheral neuropathy that can result, as well as the retinopathy that can also result from uncontrolled diabetes. We also want to make sure that we explain to the patient the different signs and symptoms of hypoglycemia. Being on oral or even insulin therapy, the patient can have signs and symptoms of hypoglycemia, which is defined as a blood glucose of less than 70. So if patients start to have dizziness, shakiness, hungry, nervous, or upset, or even sweaty or a clammy feeling, it's important to counsel our patients to let them know that they can treat the hypoglycemia if it's less than 7%. So if they're having these symptoms and then they check their blood glucose and it's less than 70, it's important to let them know the steps to take, and it's called the 15 by 15 rule. So you want to check your blood sugar, eat 15 grams of carbs, and then wait 15 minutes for the sugar to get into the blood, and then check your blood glucose level again. So 15 grams of carbs, you can tell the patient to have 3 glucose tablets, a half a cup of fruit juice or regular soda, 6 or 7 hard candies, or actually just 1 tablespoon of sugar, which is probably not the best idea, but it can be 15 grams of carbohydrate and get the job done. So once the patient ingests the 15 grams, then they wait 15 minutes, probably will start feeling a little better, and then they check their blood glucose again. If it's still less than 70, then they just repeat. It's also important to let the patient know signs and symptoms of hyperglycemia. So if they have polyuria or frequent urination, they're always thirsty, they're hungry, they're drowsy, they may have dry skin, or if the patient has difficulty healing different wounds on the body. These are all different signs that their blood glucose levels may not be controlled. And it's important to let the patient understand that these are the signs and symptoms to look for.
So I'm going to talk about the classes of oral medications. The first class of oral medications for diabetics would be the biguanides, which the most common drugs would be the metformin and the metformin XR. The way this drug works is that its hepatic glucose production decreases, which decreases intestinal absorption of glucose and improves insulin sensitivity. It reduces A1C by 1 to 2%, and some of its clinical purpose is that it's first-line therapy unless contraindicated, and it has GI side effects. Also, it can cause vitamin B12 deficiency and decrease cardiovascular disease. Patients that are diabetic should be on biguanides unless it is contraindicated. Another class of oral medications would be the sulfonylureas. These would be glipizide, glipizide XL, glimepiride, and glyburide. The way these drugs work would be it binds to receptors on pancreatic beta cells, which increases insulin secretion. They have an A1C reduction of 1 to 2%, and some of its clinical purpose would be hypoglycemia and weight gain. Next class of oral medication would be the alpha glucosidase inhibitors. These would be acarbose and miglytol. The way these drugs work is that it slows down carbohydrate absorption and digestion from GI, and has an A1C efficacy of 0.5 to 1%. The clinical purpose of these drugs is it has GI side effects and it requires frequent dosing. DPP-4 inhibitors, the drugs that are in these classes would be alogliptin, sitagliptin, saxagliptin, and linagliptin. The way these medications work is that it increase glucose-dependent insulin secretion and decrease glucagon secretion. Its A1C efficacy is 0.5 to 1%. These medications are generally well tolerated, however it may worsen heart failure and pancreatitis. Another class of oral medication would be the meglitinides. The drugs available for these would be ripaglinide and naglitinide. How these drugs work is that it closes potassium ATP channels on beta cells of pancreas, which increases insulin secretions. They also have an A1C efficacy of 0 to 1%. Some of its clinical purpose is that it requires frequent dosing, hypoglycemia if you don't take with meals, don't take it if you don't plan on eating, and you need to take 15 to 30 minutes prior to eating, and it may cause some weight gains. Another class of oral medication would be the thiazolidinediones, or TZDs. These would be your pioglitazone and rosiglitazone. They activate nuclear transcription factor PPAR gamma, which increases insulin sensitivity. It has an A1C efficacy of 1 to 1.5%. Some of its clinical purpose would be it improves lipid panel, weight gain, and bone fractures, and MI, heart failure, and edema.
Next up on the classes of oral medications, we have the SGLT2 inhibitors. This includes canagliflozin, which is Invokana, dapagliflozin, which is Farxiga, and empagliflozin, which is Jardiance. These work on the sodium glucose transporter 2 receptors in the proximal tubules of the nephron, basically to prevent reabsorption of glucose in the kidneys. Because of this effect, they can cause, of course, genitourinary infections. All three of these classes on this specific slide have A1C similar A1C efficacy of 0.5 to 1% inability to lower the A1C. The next class is the bile acids quotient, which would be colesevelam, which is also known as Welchol. The mechanism of this drug is it binds to bile acids in the intestinal tract, which increases hepatic bile acid production. Now, this specific mechanism probably mostly applies to hyperlipidemia, which this drug is also indicated for. The mechanism of action specifically in diabetes is actually unknown. Some clinical pearls, though, if the patient does have that hyperlipidemia, that can help lower that LDL, but because it's a binder, it can decrease absorption of other meds in the GI tract. And then the last class of medications that's very not really used is the dopamine 2 agonist bromocriptine, brand name Cyclocet. This one also, just like the class says, it's a dopamine receptor agonist, but specifically this mechanism is really unknown in diabetes. It's thought that the dopamine is believed to be associated with the circadian rhythm in the body, which affects obesity and insulin resistance. A1C efficacy of 0.5 to 1%, and a clinical pearl is the side effect of it could be dizziness and syncope. So now that we've gone through all the medications, we kind of just wanted to go through what the guidelines say in terms of what kinds of medications to choose, when, etc. So first up, we have the AACE/ACE 2016 profile of medications. This slide is really helpful because it helps compare all the main side effects that you may experience with the different classes of diabetic drugs. So of course we're concerned with which drugs cause hypoglycemia, which would be the sulfonylureas and the insulin, weight gain or weight loss, how it affects renal function or if it's contraindicated in renal function, GI upset, cardiac effects, and also bone effects. This next slide is the ADA 2016 guidelines therapy chart. And basically, we always want to start first line with monotherapy with metformin. And as you move from monotherapy to dual therapy to triple therapy, you always want to wait at least 3 months in between adding on that next medication. If at that 3-month mark there is no, or the patient hasn't reached goal of A1C, that's when you consider adding on an additional therapy. So metformin is always first, and then from there you always want to add on a different drug class. And this chart does have some helpful tips of efficacy, hypoglycemia risk, weight, side effects, cost, etc. And then this last algorithm is also very helpful. It's the AACE/ACE 2016 guidelines algorithm. This one is very helpful because this gives us a hierarchy of drugs to use. So as you can see, like if you're looking at the dual therapy section, after you've, of course, had metformin first line, it kind of gives you that recommendation of the GLP-1 receptor agonist would be an awesome addition for the awesome addition for the dual therapy above the SGLT2, which would be above the DPP4s, etc. So back to patient DM, how does this apply to our patient? So why did we choose to go with the triple therapy with our patient and add that Invokana? So the patient had been trending down in A1C from the previous visit, which was 3 months ago, from 8.5 to 8.3. If they were trending up, we might consider something else, like telling them they really do need to add insulin. But of course, the patient is not interested in it at this time. And since they are technically still trending down, that's why we decided to choose it. Also, it's appropriate to add on additional therapy because it's been 3 months since we've had any changes in therapy. And as you can see from the previous slide, besides the GLP-1 receptor agonist, which is an injectable medication, the SGLT2 and the DPP4 inhibitors, which the DPP4 inhibitor that the patient is on is the Jardiance. And then the SGLT2 is the Invokana that we want to add. Those are both high on the list for the suggested hierarchy for this patient. Here are our references. Thank you for listening. Please let us know if you have any other additional questions. Have a good day.